Good afternoon, everyone, or morning, depending on where you are, or evening, depending on where you are. This is an international conference, and welcome to the 2022 Thyroid Cancer Survivors Association International Conference. It is a pleasure to host today Dr. Susan Pitt, who is not only an distinguished thyroid cancer endocrine surgeon, but a former faculty member here where I am from in Madison, Wisconsin. She now is in Ann Arbor, Michigan, and I've got a quick bio of hers to read. She is an associate professor of surgery and director of endocrine surgery health services research at the University of Michigan in Ann Arbor, Michigan. Dr. Pitt's clinical practice focuses on surgical treatment of thyroid, parathyroid, and adrenal gland disease. Dr. Pitt's research is funded by the National Cancer Institute and focuses on improving patient outcomes, patient-doctor communication, and treatment decision-making while reducing unnecessary care for patients with thyroid cancer. To facilitate this work, Dr. Pitt founded The Choice Collaborative to compare health outcomes in cancer experience. Dr. Pitt received her medical degree from the Medical College of Wisconsin and her master's in population health science from Washington University in St. Louis. She completed her general surgery residency at Washington University in St. Louis and an endocrine surgery fellowship at Brigham and Women's Hospital in Boston, Massachusetts. It is my distinct pleasure to welcome Dr. Pitt today to this session of improving patient outcomes. Sorry, I want to make sure I get this title of the session correct here, and my computer's not cooperating all of a sudden. Dr. Pitt, I'll let you introduce the session title here, as it's not populating for me right now. But please, everyone, welcome Dr. Pitt.
Well, thank you so much for the warm welcome. I'm really excited to talk today about improving thyroid cancer patient outcomes, experience, and treatment decision-making. I'm going to try to talk for the first kind of half of the session and then, go through questions for the second half. If they're really burning questions, try to hold them if you can and put them in the Q&A, and then we'll go through those at the end. I don't have any real disclosures related to any of this work other than it is, a lot of this has been funded by the National Cancer Institute, as well as some other organizations. I think it's hard as I go through some of the research that we've done. Some of the results may not identify with everyone's experience. And so always kind of keep that in mind, that we try to say that this is something that we've seen a lot of patients or many or some, experience. So with that, I'm going to try to get my slide to advance. For me, a lot of times what's interesting is what kind of keeps you up at night, right? So like, what do you want to do? What's your passion, right? That thing that you think about all of the time. So a lot of this for me, what keeps me up at night is my patients with thyroid cancer, who I think sometimes I didn't realize during training, but once I became faculty, really have experiences after surgery and going on that they didn't necessarily expect beforehand. And I don't think that we always prepare our patients best. And that's why I got really interested in this. I think the other part that really kept me up at night, is over the last, 20 to 30 years, the incidence of thyroid cancer has increased dramatically. And this has been described as an epidemic. And so why is this happening? And that's where my interest in researching this area. There has been some concern about really small cancers that are, less than a centimeter or just millimeters, and whether or not we're, diagnosing too many of them because they might not progress or something like that. And that was also part of kind of what drove me to do some of this work around whether or not there's any thyroid cancer, overdiagnosis, because what happens if you treat something that, may have never been clinically applicable, then people have the harms of the treatment that are, for many patients, you need, your surgery, you need radioactive iodine and all of those things, but there are a lot of complications and issues related to quality of life and costs that can come to that. And then the other thing that really pushed me into this space was that initially the treatment options, for thyroid cancer were really taking out the whole thyroid or half of the thyroid. But around the time that I started in practice, active surveillance for really small cancers was added. And I became very interested in sort of how that was going to be perceived, whether patients would want to undergo surveillance as opposed to surgery, whether doctors would want to offer that. And so that sort of is just sort of the setup for, where a lot of my research came from. And because you now have all these different options, how much of the thyroid do you remove? Do you remove lymph nodes, or do you monitor this in surveillance? It really makes shared decision-making very important. And this is just a model. The model is really not important at all, but, I think it changes the conversation between, for many things in medicine, you have X problem, we have Y treatment, and it's a very linear, obvious thing. But when there's multiple treatment options that are all, equally effective at treating the cancer and preventing recurrence and things like that, then I think it really becomes important to, make sure that we're doing what's best for each individual patient, because what's really important to the first patient I see of the day may be different than the second or the third or the fourth patient I see each day. And so, I started getting into this and figuring out, well, how can I help? And I really do enjoy the research process. And I'm going to talk sort of about 3 areas where we've done a lot of work. One is interviewing patients, and that's sort of the icon up on the left. I realize that there are male and female patients, and this is just meant to sort of help organize kind of the talk. We've done a bunch of work with stakeholder engagement, some work that Timothy helped actually me arrange, and then some really looking at the actual conversations themselves and what's happening at the time of the decision making, and how can we improve that. So I'm going to start by talking about some of the interviews that we've done with patients. This is one particular study where we actually interviewed 85 patients, and they all had either papillary thyroid cancer or they had a biopsy that was suspicious for cancer. And where we were really just trying to understand what are the experiences of patients at the time of diagnosis. And one overwhelming theme that we heard from patients was like, get it out, right? Like, oh my God, I've got a cancer, get it out of my body. We don't want this. There was the reaction like, it's cancer. And then from there was this urgency that we heard from a lot of patients about, well, let's get this done like as soon as we know. And I'm sure that during the pandemic, as treatment delays have increased or time to treatment has increased, that this has even been exacerbated even more. And most of these interviews were all done prior to the pandemic. And then there was a lot of concern, like, could the cancer be spreading? And there was also a lot of assumptions around surgery would just be this fix. And we heard, these are some quotes we heard from patients that I'm just going to show you, and some may resonate with you and some may not. But, people said things like cancer, the word cancer, just hearing it was a little hard. The little things at the bottom, the patients were just assigned a number. If there's an F, it's a female, and if it was an M, it was a male. And then PTC is short for papillary thyroid cancer. We heard things like, it needs to come out. They just need to do it. Let's put it that way. That was sort of, the get it done. I could care less if I'm going to have a scar. I care, how I look, but it's most important to get it out. We heard things like, once I get this thyroid out and the cancer done with, I'll generally just be feeling better, right? Like it's this, you're going to get better as soon as the cancer part is out. But I think we don't always prepare everybody for what's next. And then one last quote that I'll show you is just, I'm going back to normal and routine in the way and how everything was before. And this assumption that there was sort of this fix and you just go back, as opposed to, this new normal that we've all learned about since the pandemic started. And so from this work, some conclusions that we made around patient experience from thyroid cancer diagnosis was that there was a lot of anxiety and fear related to the C word, being diagnosed with cancer, which is natural and normal. That the sort of excellent prognosis that goes along with thyroid cancer isn't necessarily reassuring to everyone, because it's a cancer. And we all, have been taught and brought up to, think that cancer is a bad thing, which it is. And then, many patients viewed surgery as this way to fix things and return to normal. But, all the effects from surgery and radioactive iodine, if you need it and all of that, it's not like you ever really go back to the way things were prior to the diagnosis. And one thing I didn't sort of point out, but a lot of our patients that we interviewed seemed to minimize the complications. It wasn't, like, I don't care about the scar, I don't care about my voice, I just want the cancer out. But then if something actually, does happen, then you care about it kind of downstream. This is just a subset where we really explored this idea about the good cancer, because it was a theme we heard a lot from patients. So all these patients that we interviewed were a subset of the prior study, and there were 31 who had papillary thyroid cancer. And we really just wanted to characterize their thoughts about the favorable prognosis in the actual term good cancer itself. we found that patients heard good cancer related to thyroid cancer diagnosis from multiple different sources. They heard it from their healthcare provider. They saw it on the internet. Their friends or family said, oh, I heard that's the good cancer to have, and even just individuals' own personal perceptions of cancer. And it had an impact that really seemed to, at times, both have a positive connotation for people, and other times it was a negative connotation, right? If it's good, well, then it makes me feel a little bit better. You're reassured. Whereas if it's negative, you're also like, well, this might, I'm confused, it's cancer, but it's good. That doesn't ever really seem to go together, like it's an oxymoron or something. And some patients felt invalidated. And so the sort of conclusions that we took from this related to patient experience were that there are a lot of mixed positive and negative emotions about the good cancer, that the terminology can really diminish patients' experience of a new cancer diagnosis. And because of that, it's something that we thought that a healthcare provider should at times use the term either not at all or just very specifically at certain times. This is a meme, actually, I saw on the internet after we had done this work. And I think it really summarizes or explains how a lot of patients feel, right? If you're going to have cancer, thyroid cancer is the one to have, said no person who's ever been diagnosed with thyroid cancer. And I think that we need to remember that on the provider side, because it's really important to validate everyone's experience and treat every individual as an individual. This is one other study I'm going to show from this work where we really focused on the needs, right? So there's this experience, right? You got to get it. It's cancer. You got to get it out. I don't really want to be told it's a good cancer, but what do I need, right? How can we better support patients around the time of, the diagnosis? And so we really were looking at this time between diagnosis and actually undergoing surgery, which for some people can have lots of delays. You're waiting for your insurance to approve to see the actual, the surgeon, and getting, your surgery approved, by your insurance. And there's just, it seems like it just takes, way too long. And what we found from this is that there were lots of different areas where people had needs, but ultimately a lot of it really came down to this time of this sort of decision and this need for reassurance. And so there was a need for kind of informational support, but people really wanted it individualized, right? You can get generalized things off the internet and information there, but does that actually apply to your case or not? That's very different for each person, right? And then emotional support, right? So if using terminology like the good cancer is like minimizing patient experience, then we're not actually validating the cancer experience or empathizing or providing sort of the appropriate emotional support. And I think, we saw a lot, this big theme around people just really wanted to be treated as an individual and respected. Some of that came from in our interviews, people, having lots of questions about radioactive iodine or other things that were next step. And they felt like the surgeon kind of put them off. I'm like, we'll talk about that later if you need it, and that kind of thing. And they felt a little bit minimized. And so they really wanted to be treated as an individual and have their specific questions answered. And we felt as though a lot of this, the surgeon and the relationship with the surgeon could be a good source of the information, the emotional support, the treatment as an individual respect, and then provide reassurance around the diagnosis. And so I think implications, somewhat going forward, and for patients, I think there are real opportunities for improving both the informational and emotional support for patients with thyroid cancer at the time of diagnosis and prior to undergoing surgery, and of course, throughout treatment and survivorship too, but there's always been a bit of a focus on that. And so I think that the point where we kind of came into this research was looking at that really early time. And there's actually some data from other cancers that show if people are better supported around the time of diagnosis and treatment, they have improved quality of life later. And that, just related to how they were treated in that beginning part. And so that's really where a lot of my work is focused. And then I think, this can come from surgeons and from other sources. And I'll get into that a little bit. The other part I wanted to talk about was stakeholder engagement. And so I'll explain a little bit kind of what that is. It's a term that's been kind of thrown around a lot, but I'll explain it actually on the next slide. But with what we really wanted to do was take a lens that looked at this from everybody's side, right? So like we can interview patients and we can interview physicians, but what if we get everybody in the same room and we all talk together and really kind of get down to the nitty gritty of what people need. And so our questions that we really wanted to answer from our stakeholders were what kind of information do people actually need when they're making their treatment decision? And then I think part of it too was like, what are the barriers to less extensive treatment? This idea of active surveillance had just come out. This is 2016, when we were doing this research or starting some of it and starting our stakeholder engagement. And that was a totally new concept for thyroid cancer. And then we also went back to the interviews that I just described, and it wasn't necessarily part of what the interviews were designed or people were asked, but we wanted to actually look for like what were patients telling us were actually important to their treatment decision, even though we weren't specifically asking about that, and kind of were there any attitudes or beliefs expressed about any less extensive treatment. And so in terms of stakeholders, we got together a group that included 4 patients as well as 2 of their family members who came. We had 5 different endocrinologists, 2 fellowship trained endocrine surgeons, 1 general surgeon who did a lot of thyroid surgery in the community, and an otolaryngologist, an ENT, who does a lot of thyroid cancer, as well as a radiologist, because we started realizing that the diagnosis starts, prior to the actual, day you get your cytology back after the biopsy, right? The radiologists are important in finding the thyroid nodules and then in biopsying the thyroid nodules. And we really wanted to make sure that the patients felt heard and empowered and weren't going to be shadowed by the physicians. And so I put this meeting schedule there only to show you that we had them kind of meet individually. So the blue boxes were the doctors and the orange were the patients and families. And we had them kind of meet separately and then together and then separately and together so that we could get consensus around different topics within each of the sort of the individual groups and then get consensus together and have sort of like a blended meeting. And we really wanted them to help us figure out like what information do patients need to make a treatment decision, and specifically like for each of the different sort of options for people who have active surveillance as an option, and then lobectomy or removal of half the thyroid and total thyroidectomy. And this is not meant for anybody to read it, but just to show you that we really went through each of these areas to really hone down exactly what people needed to know. And so from that, we developed an intervention with them. We went through several different types of patient-oriented or patient-facing materials that could be provided. We went through different kinds of websites, shared decision-making tools, and different things. And the group that we engaged really wanted something that was simple, that could be easily sent out to anyone, anywhere, but also could be accessed on the internet, and that kind of thing. And these are initial prototypes. These are not the final, so don't get excited about it. But what we developed was a question prompt list and a treatment comparison chart. And the question prompt list has 14 to 15 questions that you should think about asking your surgeon. And these are meant to be delivered prior to actually, after diagnosis and prior to seeing the surgeon, and things that you wouldn't necessarily think to ask about, and then the comparison chart really just puts everything, it lays it out side by side in a really nice, simple format. And we've had these available on the internet for a while, but we're currently trying to study to see if it really actually makes any difference in patient experience. And so the study design itself a little bit, if you kind of look at along the bottom here, is that these materials will get delivered sometime in this period between diagnosis and sort of consultation with the surgeon and treatment decision making, so that the goal of the question prompt list is really to increase patient question asking and empower patients and to make them feel more confident in communicating with their surgeon, so that you have some information prior to seeing them. And then the comparison chart is really meant to increase patients' knowledge about the different outcomes and their awareness of the different options, because we found that not everybody who had multiple options were even getting multiple options offered, and that a lot of people weren't thinking about certain outcomes that they didn't know exist. Like most surgeons, because we audio recorded some conversations too, and I'll talk about that in a minute, but they don't talk about the like possibility of fatigue. They don't talk about the need to like take your thyroid hormone on an empty stomach an hour before you eat or drink anything else, and all of these other things that actually really impact quality of life, because it's more about the surgery and the possibility of complications. And they might describe parathyroids and calcium in major detail, but kind of totally and be like, well, there's this pill you got to take, but they just don't kind of cover everything. And so this is really to help patients who don't necessarily know about all those other effects that can happen from treatment later, to ask about them and be more informed at the time of the decision. And so I'll talk a little bit about the treatment decision-making conversations next. We've done a couple of studies for this. We've only published the one, so I'm only showing that work so far. The other is in press, so meaning it's about to be published soon, but I don't have the final everything from that. Oh, I somehow clicked on my annotate thing. Let me turn this off so I can get the next slide for you guys. So this particular study, what we did is we just audio recorded conversations between patients and surgeons during treatment decision making. We had 30 patients so 2 patients saw the surgeon twice before making a decision. And all of these patients had papillary thyroid cancer that were relatively small, and they had no lymph node involvement. And then there were 9 surgeons who participated at 2 different hospitals. And we really just wanted to look at the content of the communication, because there's such that reaction I talked about like getting it out, and feelings around and thoughts and emotions around good cancer being a term used. The first study that we did looked at the emotional aspect of the conversations, but the one that's in press that I mentioned right now really looked at sort of what's the other content, like what are all the things that people are asking a lot about that we are not telling patients about up front. And we want to use that information to help train surgeons better to talk about the things that really matter to patients, as opposed to just those things that are complications, or things where we feel like we have to do this risk disclosure around informed consent in case somebody, for medical legal type reasons. And so we looked at this from a very specific model, and this part's not as important, but in general, this actually comes from behavioral economics and about how people perceive risk, because a lot of times risk is actually perceived more as an emotion and a fear about something happening, like you get on an airplane and the airplane could crash. And most of the time that does not happen. That's why we all keep getting on airplanes. But there are some people who have, what you could consider an irrational fear of flying, and are unable to, even though they know the probability of the plane crashing is 0.00001 something %, right? It's super low. And so we wanted to sort of look at the conversations and about how the risk was being felt, as opposed just to being, telling you got a 5% chance that, I don't know, you'd have a temporary voice nerve injury or something like that. Because at least in the behavioral economics kind of world, it's those emotions and feelings that actually determine people's decisions more than the sort of cognitive evaluation. And everybody's a little bit different, so this isn't necessarily true across the board, but all of those other things, how you kind of anticipate what you think it's going to be like on the other side after surgery, after radioactive iodine, all of those things help, determine what you're going to choose. And if we're not preparing you to actually understand those things later, then we're not doing a good job. And we also have to, you can see in the lower left part of the little graph, you have to understand this in other terms of how people feel. So their past experiences, vividness is sort of how much someone can picture that future outcome, right? Like if you're a singer and a future outcome could potentially be a voice nerve injury and not being able to sing anymore afterwards, that person may be able to really see that and really feel that and have fear around that way more than, I don't know, someone who doesn't use their voice, much at all. And you probably think that that's a silly concept because we all talk all the time, but go with me here. And so we don't have a figure per se related to this study, but there were a lot of implications around the kind of the emotions and what were talked about, and some observations. One was that we realized a lot of patients expressed emotion indirectly, like it may have been in the form of a question, right? Like, is there a chance the cancer has spread? Yes, there's like a factual part about that, like, is it in the lymph nodes or is it not in the lymph nodes? But there's an underlying fear there, like, oh my God, what if it spread? What does that mean? All of that kind of thing. And the surgeons in the conversations really seemed to respond with like facts and data, and not say things like, wow, I'm sure that's got to be a major concern of yours, and sort of validate the feeling prior. And there are studies that show that if the emotional part of something like this is a question like this is addressed first, people actually remember the response better, a better recall of it later. We, in terms of what the surgeons were saying or doing, they did tend to acknowledge the emotions that resulted from sort of the C word, but not across the board. So not all of the surgeons did that. They tend to emphasize that kind of that, thyroid cancer is, most thyroid cancer is very slow growing. A lot of them emphasize that there was no rush to make a decision. And we tried to focus on the things that they were doing well. And also the paper itself describes a lot of things they didn't do well, but that's where we have opportunity. We can learn from the conversations and improve them for everyone. And then they often described emotional outcomes, and this goes a little bit into this last point about where patients and surgeons, we felt like both were doing this, where a lot of times, removing the entire thyroid was, if someone had the option between removing half and the whole thing, there was this idea that you would have more peace of mind or feel more complete, or you might have less worry or something like that. And those are all like more emotional outcomes than cancer specific outcomes like recurrence or survival. And frequently with active surveillance, that's part of where the underlying theme of this talk came from, was that, surgeons would say something, well, if it's going to keep you up all night, like, thinking that the cancer's still in your thyroid, then, and you're going to have worry about it, then, don't undergo surveillance. And, the study itself was really focusing on patients who had all these options. They could, many had the option for active surveillance or removing half the thyroid, or they had the option of removing, half or the entire thing. And so for me, like, this is back to the beginning, right? Like, what is it that's keeping us up at night around thyroid cancer and diagnosis, and how can we make things better going forward? And so I'm going to end with a little bit about what we're actively doing to continue to support patient and physician decision making, and then hopefully we'll have a lot of time for discussion and question asking. So the things that our team is doing now, one, I mentioned it was mentioned in my bio about the Choice Collaborative. So within that, we're running 2 studies. One we finished, but we had 12 institutions around the country who helped recruit patients to participate in the Choice study, which is going to help inform another patient-oriented intervention, and I'll show you that in a second. And then the Choices study, we're actually doing something in more like a hypothetical setting, because we weren't sure how it would be perceived by patients who had thyroid cancer. So the people who are participating have had a recent thyroid nodule biopsy, and but it's come back benign. And then we're asking them in a very short time period to imagine what it would come back as cancer, because that's something that they probably were thinking about and worried about in the meantime. And we're having them watch videos with different types of surgeon communication, some that has increased empathy and reassurance, and other things, to see if there's preference around what types of communication people would prefer to have. And that would help us develop a surgeon-oriented or endocrinologist-oriented, communication intervention of what's to help better support patients with thyroid cancer. So just briefly about the Choice study, the inclusion criteria are not really important, but this was comparing health outcomes and cancer experience. And We recruited 125 patients from 12 different places around the country. And what we did is we really were wondering, like, right, I know what's keeping me up at night, but what's keeping the patients up at night? This is just an example of kind of the exercise that we had them do, where people had to take 100 points and allocate them. And we actually had the stakeholder group that I described before, hone down what are the 10 most important things people should be thinking about in terms of outcomes of their treatment. And they weren't exactly this. This was a mock-up for it, but they were these things. And we looked at, right, are people thinking about how long they're going to live, the possibility of the cancer coming back, just the act of having the cancer removed from the body. Are they worried about their worry? Like, are they in touch with their emotions enough that, like, they're thinking about what the treatment's going to do for their worry? Returning to normal life, energy levels. So you can see the list here, and we're in the middle of analyzing this now. But one of the things we're realizing is that there's very different patterns, right? There's some people who really, maybe pick the green ones, or some people who pick the yellow ones here and whatever. And so how can we use all of that information to help people be more satisfied with their outcomes and more prepared for what that's going to be like in the future? And so we actually had the participants do this again 9 months later, and go and say, if you had to, advise yourself before, what would you have, how would you evaluate these different outcomes now, and how important would they have been? And we're using that information to help, future patients have a more optimal experience in the future. These are all the people that have helped me do a ton of this work. So I can't, do anything without them. I've had several mentors, a big research team, a lot of clinical colleagues who've helped, really, help recruit patients, help treat patients. I can't do what I do without them doing some more, being a little more clinically busy than I am at times, because the research does take time. And I just wanted to point out, that, these memes, I've seen them several places, the SOMI cards, but I see all different kinds of them, because I do think thyroid cancer is an area where because the prognosis is good, we really, really, really have to, like, make sure that all the other parts of the experience are adequately supported and treated. And I think that a lot of patients get passed off between one provider and the next provider, and that can really leave gaps in experience. So thank you all for listening to me. Hopefully we can help everybody sleep a little bit better. And I'm happy to go through questions.
Yes, Dr. Pitt, thank you for that wonderful presentation. We do have a few questions in the Q&A box, and just a reminder for everyone that the chat is disabled. Please use the Q&A box to submit your questions for Dr. Pitt. The first question is a question about the overtreatment versus overdiagnosis. And this person believes that overtreatment is more of a problem versus overdiagnosis. This person also wants you to know that as patients want to know if they have thyroid cancer, first of all, and then also be included in treatment decisions. But again, the question is about overtreatment versus overdiagnosis.
Yeah, I almost hesitated putting it in there, but I feel like it's a concept that's important, and we should all at least, think about, because there's most thyroid cancers, right, aren't necessarily overdiagnosed, right? But if they are, treating them can result in overtreatment. And then there are people who have thyroid cancer that's not overdiagnosed, that are also overtreated. So it's a little bit of a complex, I think, paradigm. Because inevitably, if you're overdiagnosed and treated, then you're overtreated. But you can be not overdiagnosed and overtreated. And over time, we've de-escalated all of the treatment, right? We give radioactive iodine a whole lot less. We give smaller doses when we do give it. We have gone from, taking out the entire thyroid and prophylactically removing all of the lymph nodes to, at times just removing half the thyroid. And so I think that there is, some truth to what you've said. The guidelines did change around 2015 for the American Thyroid Association and the American College of Radiology. And so we biopsy a lot less. So the actual incidence in the last like 3 years or so of thyroid cancer, so the number of new patients diagnosed has actually gone down for the first time, and it was going up faster than any cancer. So I do think that, you know, there's a lot of changes going on. And so I do think overdiagnosis itself is actually becoming less of a problem for sure.
So the next question, I think, speaking about what's keeping people up at night, this individual is talking about their problem with insomnia, I think, as a result of their replacement dose. So, you know, Synthroid or levothyroxine, or and is just asking if, you know, would reducing the replacement dose help? It sounds like they've tried other avenues like not drinking caffeine, alcohol, tobacco, not napping, etc. So I don't know if you have any opinion on that.
Yeah, no, it's a really good question because it relates, you know, to the underlying some kind of theme of the talk. You know, it's hard to know, and like without going through someone's medical record, I can't give like specific advice, but certainly some people do have trouble sleeping related to their thyroid hormone. And I know frequently, you know, we've played with, do you take it first thing in the morning on an empty stomach, you know, and wait, you know, your hour to eat or drink anything, and, you know, time for other medications, or do you take it at nighttime? And sometimes just switching, you know, but you have to take it, you know, at least 3 hours after you eat. And if you go to bed, certainly after dinner, that doesn't work well, and that kind of thing. And, you know, all those times, you know, you may hear slightly different exact times from different physicians, because it's not like a perfect science. Like if you take it an hour and 1 minute after you eat, or 59 minutes after you eat, or sorry, after you take it, if you eat. And so it's hard to know for sure, but sometimes either decreasing the dose as you have in there, or changing the timing of when it's taken can help with that. But there's also like you know, several different causes of insomnia, so it's really hard to know.
Our next question is about continuing surveillance for microcarcinoma in lymph node tissue. Is that a reasonable consideration?
I'm assuming this is like about recurrence, because if, you know, if you have you know, diagnosis, like I was talking about active surveillance at the time of diagnosis, to something that's very small and limited to the thyroid. You know, in terms of if this is like a recurrence, you know, a lot of that depends upon how many previous surgeries you've had, how large it is. Sometimes we'll wait to treat something till it's bigger, because it's therefore then easier to see and make sure you've removed and that kind of thing. So it's really hard to know exactly what the attendee's situation is, to be able to fully answer that. But you know, at least in something that's a recurrent lymph node, sometimes we will do surveillance for those. And there are other options other than surgery, like alcohol ablation. And they're starting to try radiofrequency ablation for some of those too.
The next question, the individual is just saying that, you know, you often hear people say this type of cancer advances slowly, don't worry, but how do you know how slowly, and how do you try to stay calm without knowing?
Yeah, I mean, that's a really great question, right? Because, you know, so many of us too, even on the physician side, like there are occasionally, is particularly like around papillaries, that, you know, will grow quicker later, you know, if they've been observed for a long time. But I think, you know, you have to be kind of reassured by the data that happens, you know, like less than 1% of the time. So it's very uncommon, and that, you know, either, you know, symptom development should happen, or your ultrasound's going to catch it, or, you know, things like that. And you're getting, sorry, I got distracted by the next comment. But, you know, I think it's hard, you know, but I think sometimes, like, whether it's the staying calm, is it like, do you need, you know, other types of interventions, like, right, is the if just the monitoring and the surveillance and the fact that it's, you know, 99+% of the time not going to change its, you know, pattern isn't enough, then do you need, you know, kind of like counseling around, like helping with that, or, you know, other types of support. because it's cancer and it's scary. And I think that, that's where we're going with our surgeon communication, right? Like, how can I get better at actually providing reassurance? Because I may be someone who's reassured by the data and someone else may be, reassured by a hug. And they're two very different, actions.
All right, then our next question is actually more of a comment for Dr. Pitt. It says, hi, that this person had their treatment at the Siteman here in St. Louis. So it is nice to hear from former Washington U girl, as this person went there too.
The next individual is talking about having having some issues with insurance covering the annual scans, and wondering your opinion on overtreatment and how necessary continuing yearly treatment and RAI exposure is. So is there harm in skipping a year?
Yeah, it's very interesting. I think that this is an area that where over surveillance is now going to be a big topic coming up. But the National Cancer Institute is funding a lot of research in this area of like, where's the unnecessary care that we're doing? Like, how can we make the stuff that we are doing that needs to be done better, but how can we also stop doing things? And I think that I don't know that anybody knows the true answer to like that question. Certainly if the thyroglobulin level has been monitored and it stays low, like that's very reassuring. A lot of times the a recurrence is picked up with a thyroglobulin level, assuming the cancer produces thyroglobulin faster than something might be seen on ultrasound, depending upon the quality of the ultrasound. And so it's hard to know about it, but I'm surprised to hear it's the first time I've heard of someone not having insurance cover it. But at least for an ultrasound, they, you would think that that should be covered. And there are a lot of physicians who will do the ultrasound in the clinic. So like it costs way less if I do it in the clinic than if I send someone to radiology too. And so that would be another avenue of if someone wanted to have that done, is to see someone who will do one in the clinic as opposed to separate, because then it's like a tagged add-on charge, as opposed to like a whole, what's the right word? Like its own whole like procedure or event.
Thank you, Dr. Pitt.
Mhm.
Our next question is about a person who had a cystic mass that was biopsied, and it came back as metastatic thyroid carcinoma. So they are wondering about if there are any tests that can be done to identify the cause of how their thyroid carcinoma would have ended up in that mass, and why it would leave the thyroid.
Yeah, there's it's not uncommon to have like so the cancers can regress. It's uncommon, but we've certainly seen cases where thyroid cancer ends up in the lymph nodes or someplace outside the thyroid, and the primary is never found. And the assumption is generally that the thyroid, whatever was originally the cancer in the thyroid, is that it regressed. And I've certainly seen cases where it's a 4 millimeter or 5 millimeter primary, and it spreads, and we're sure that this has to do with like which of different types of genes are actually like mutated that within the cancer that allow it to either spread more quickly. And that's, I think, why some people are hesitant around things like active surveillance, right? So there's, a small percentage, might only be 2 or 3% that will spread if you monitor them. And so other thing to think about is you can have, like, depending upon where a mass is, like you can have ectopic thyroid tissue also. As the thyroid develops, it starts like way down near the base of your tongue and moves into your neck. And so you can have ectopic thyroid up here, but it can also travel like lower. So in the central neck, you can have non-cancerous thyroid tissue. It wouldn't spread to the lateral part of the neck. So without knowing all the entire sort of situation, that could be another possibility.
Did you interview patients who fall between low risk to intermediate risk and their decision making around radioactive iodine treatment post thyroidectomy?
Our group hasn't done that. There's a endocrinologist in Canada named Dr. Anna Sawka, Sawka. And she's done a lot of work and has interviewed patients around the decision-making related to radioactive iodine, so that are more in that low intermediate. And I think she's even included some high risk, patients in those studies, mostly because some of her work, they've developed an intervention to help people with that decision. Anyway, so like I said, I haven't done that personally, but the work is being done in that space.
Thank you, Dr. Pitt. Our next question is about what is the difference, if there is a difference, between brand name Synthroid and what I assume to be generic levothyroxine.
Yeah, I mean, a lot of this is just manufacturer, and I can't remember who made Synthroid as the original, but if it's, each, there are many different manufacturers of the different medications, and so they are like, if you have the pills side by side, they can be the same, but a lot of this has to do with who manufactured it first and who has kind of like the name, proprietary name to it, and gets to call it Synthroid versus everybody else has to call it levothyroxine. And where it comes in is that sometimes if you take 150 microgram pill from 2 different manufacturers, they're not really actually the same. And your CVS and your Walgreens does not have to tell you if you're taking generic, if they change who the manufacturer they're getting it from. And so for some people that will mess up kind of their replacement. And so that's why we'll put sometimes, we only do brand name. It's because we just want to make sure you're only getting it from one manufacturer. And so that's, but theoretically the molecule itself and the actual medication is exactly the same. But it's the manufacturer that differs. And so within a given manufacturer, you'd expect the 150 micrograms to truly always have whatever exactly they're putting into there. So I hope that makes sense. It's a little bit, related to who's making the pill and the distribution process.
Yeah. I know at the beginning of your presentation, you showed the slide with the epidemic rates of, the increasing rates of thyroid cancer. So one of the participants is asking, is thyroid cancer still on the rise? And if so, are there any studies as to why this may be the case?
Yeah, so if you go to the National Cancer Institute cancer statistics thing, the curve for thyroid cancer incidence had been going like this. And now at the top, and in the last 2 to 3 years, it's gone like this, and it's gone down just a little bit overall. And you can actually anybody can go on their website and you can play with it because it may not be that that's the same across the board, right? It might be that, depending upon your race or your ethnicity or your age or certain things like that, and you can actually play with it and then get it to change the graphs, and it'll give you the data. The data themselves are always like a year or 2 lagged anyway, because it takes enough time for them to actually like collect it and get it all in. But it has been on the rise over the last, like if you look at it over the last 4 decades, it's tripled. But just in the last couple of years, thyroid cancer went from being like the fastest increasing like proportion of patients being diagnosed to now it's not. So
Okay. Thank you, Dr. Pitt. Our next question is from someone who is 12 years post-Hürthle cell and papillary carcinomas. And they're wondering about the frequency of recurrence surveillance and how long that should still progress. Because they have been told not only the word cured, but that they should continue with surveillance. So they're asking about that frequency of recurrence surveillance.
Yeah, I think this is definitely an area that's somewhat debated currently because, right, like when do you stop? Like I've seen someone who had a recurrent cancer 30 years later, right? Like that's crazy. It can happen, but do you actually need like, I think depending, it has to be individualized. Like it depends upon, has it already recurred once and now we're looking for a second recurrence, or has it never recurred? So there's a lot of things like that. But what a lot of, at least the practice that, our endocrinologists do here is that after a certain amount of time, individualized, if you haven't had a recurrence, they just recommend getting an annual thyroid globulin. If your cancer produces thyroid globulin, and that way you don't need the imaging and all of that. But I think it's hard to say exactly, because it's definitely individualized and depends upon how many times it has or hasn't come back already, and that kind of thing. So, but you can have, particularly with papillaries, recurrences, later. So it just, and a lot depends upon your initial pathology too. Was there, what kind of subtype was it, and all of that too.
The next individual is a year out from her thyroidectomy, and was just noting that, her surgeon did an okay job at explaining everything, but didn't do a good job of explaining what happens next. She was told all she has to do is take a little pill in the mornings and everything would be fine, and everything is not fine.
Yeah, one of the so I will say, when I finished my training, I am guilty and probably told people the same thing. And I think part of that is, I don't think many surgeons follow their cancer patients long term, right? They then go to the endocrinologist. So the endocrinologists are the ones who are aware of this experience. And I decided that I was going to follow my patients because I wanted to know if I was doing a good job. And so for the first like 7 years of my career, I followed all of my cancer patients. Now I do it a little bit selectively, because if I think that someone's really low risk, I trust the endocrinologist that I work with to do that. And, it balances things out. But part of me thinks that a lot of surgeons don't really know what your experience is like later, because they're not seeing you later. But I do think that they tell people you're going to be just fine. And so like, that's a lot of where our work is trying to go, is like, right, I'll tell you for sure that the study where we looked at patients, the last kind of thing I talked about, where we had the 10 different outcomes that patients had to rank. And we've looked at the data for 9 months later. Thyroid hormone went from being low, on the first kind of go round, when we asked right after the treatment decision was made and before surgery, and it climbs to like the second or third most important thing, again, after recurrence and like survival, in the treatment decision. And I think we have a lot of education to do. And I think the question is, what else do we need to do in terms of skills around communication? But that's part of what our work is going to try to do, so that people, I tell patients, some people feel just fine, but some never feel the same again. And I can't tell you whether you're going to be that person or not, but you need to know that's a possibility. But I don't think that that's what, everybody's told. So I'm sorry that you didn't, have a realistic outcome, or you weren't aware that that was a possible outcome and that you're experiencing that.
The next question is in regards to someone also who had also has a microcarcinoma in a lymph node with no surgery yet on that lymph node. And they are wondering about just doing surveillance instead of surgery on that lymph node. They're classifying it as a microcarcinoma.
Sure. So if it's a little hard to know everybody's situation, but if you're diagnosed with a thyroid cancer and a lymph node at the same time, active surveillance is not a recommended treatment option. Surgery is recommended for that with, a lymph node dissection. If you're had a small cancer before and now and it was removed, and now you have a small recurrence, that's, you could choose to follow or not follow, and you could make that decision. The guidelines would say to remove it if it's safe. So sometimes it depends on where it is, and did someone are they healthy enough to undergo surgery, and then those sorts of things. So it's hard to give anything kind of individualized, but at least the guidelines for surveillance are only for, basically a single focus of cancer that's less than 1 centimeter in the thyroid, or 1 centimeter smaller in the thyroid. And so if it's not confined to the thyroid, then surgery is recommended.
Okay. It looks like the next 2 questions are asking about TSH suppression levels. So I don't know if you can speak to recommended suppression levels.
Yeah, I mean, I think this is a little bit depends upon what your pathology and how high risk you are for recurrence. So like if you're more in this low intermediate risk for recurrence and nothing's happened in the first couple of years, a lot of times suppression will stop after that. But if you're really high risk, a lot of endocrinologists will do TSH suppression, indefinitely. And so it's very individualized. So it's a little hard to give a specific recommendation. And unfortunately, I don't think that the guidelines really have a, like, on the surveillance side, like, when do we stop? Like, when do we stop doing ultrasounds? When do we, and then that's, I think, going to be a big topic of research over the next few years.
Thank you, Dr. Pitt. And I think this should probably be our last question, because we are at 1 o'clock right now, Central Time anyway, so 2 o'clock Eastern. The question is, can a person who has had a thyroidectomy live without any sort of replacement thyroid hormone pills?
If the entire thyroid has been removed, you can live for probably a couple of months. You'll eventually go into coma, and most people end up being admitted to the hospital once somebody finds them in a coma, but you can die from taking no thyroid hormone at all, like if you weren't found. So I definitely would not recommend it. But, like if, and there's a reason why we tell you have to take this every day for the rest of your life.
Thank you, Dr. Pitt. Once again, I appreciate all the questions that have come into the question and answer session. I'm sorry we can't get to all of them. I want to say thank you to Dr. Pitt, of course, for her time today. I want to remind people that the physicians and other featured guest speakers that you see at the conference here today are here because they appreciate thyroid cancer patients and want to be here as a resource for you. They are not compensated for coming here. They do this on their own time, and it is much appreciated by all of us. So thank you again, Dr. Pitt, for coming today and donating your time to ThyCa and your expertise. With that, I would like to close this session and thank everyone for their coming and their questions. Thank you very much.